To make sure we don't miss a single detail, we're going to follow a surgeon's exact thought process. We'll start with the anatomy and pathophysiology, decode the diagnosis, step into the OR for the surgical interventions and special scenarios, and then finally tackle the appendicular lump and appendicular tumors. Let's get right into it.
First up, Section 1, Anatomy and Pathophysiology. Nailing down this foundational anatomy is absolutely crucial, mostly because the physical location of the appendix literally dictates what kind of symptoms the patient is going to feel.
So here's the really important part. While the base of the appendix is reliably anchored right at the junction of the large bowel's muscle bands, those tinea coli, the tip? Well, the tip's location varies wildly. Most commonly, it sits retrocecal, meaning tucked behind the cecum. But in about 21% of cases, it hangs down into the pelvis. When it's there, it can irritate the bladder or rectum, which actually mimics a UTI or causes diarrhea. And then there's the post-ileal position. It's the least common, sure, but it is dangerously tricky because it presents with almost zero outward signs, meaning you can easily miss a life-threatening perforation.
Now, thinking about the blood supply, we have the appendicular artery. This is an end artery branching off the ileocolic artery, which brings up a massive pathological concept. There is no backup collateral blood supply here. None. So when the lumen gets blocked, usually by a hard little calcium deposit called a fecalith, pressure starts building up fast. That pressure cuts off the venous return, then stops arterial flow completely, leading straight to tissue death and perforation right at the tip.
Right, moving on to Section 2, Diagnosis and Clinical Signs. Let's step into the ER and figure out how we actually spot acute appendicitis before things go south.
You've probably heard of the Mantrals, or Modified Alvarado Score. It's a fantastic diagnostic tool that maps out symptoms, signs, and labs on a 10-point scale. The big takeaways here? Right lower quadrant tenderness and an elevated white blood cell count, leukocytosis, are huge red flags, so they're weighted with 2 points each. Other things like migrating pain, nausea, and fever get 1 point. Oh, and those labs, they often show what we call a left shift. That's just our medical shorthand for saying there's a huge surge of young, immature white blood cells rushing out from the bone marrow to fight a really severe infection. If your total score is under 4, they're likely okay. But a 7 to 10, you're almost certainly heading straight to the operating room.
What's really fascinating about these classic clinical maneuvers is the underlying mechanics of how they work. McBurney's point tenderness just pinpoints the usual location of the appendix base, but take the Rovsing sign. You press on the left side of the abdomen, but the pain shoots to the right. Why? Because you're physically pushing gas and bowel loops across the abdomen, irritating the right side. And the psoas and obturator signs are even more mechanical. Stretching those specific pelvic muscles causes sharp pain because that inflamed, angry appendix is resting directly against them.
Section 3, Surgical Interventions. Once we've confirmed the diagnosis, usually with a contrast CT in adults or an ultrasound in kids to spot that swollen, blind-ending tube, it is time to scrub in.
Let's weigh our open surgical approaches. A surgeon can use a gridiron incision to cleanly separate or split the abdominal muscles. This is great for preserving muscle fibers and getting the patient back on their feet quickly. But if the appendix has ruptured or things look really complicated, you need a much wider field of view. That means converting to a Rutherford-Morris incision. Here, you're actually cutting right through those muscle layers to get maximum access, which, as you can guess, means a significantly tougher recovery for the patient.
So what actually happens in the OR? It boils down to 4 essential steps. First, locate the appendix by tracing the colon's muscle bands right down to the base. Step 2, ligate, or securely tie off that appendicular artery so things don't get messy. Step 3, the surgeon crushes the base, moves the clamp, and sews it tightly shut with a transfixing suture. And finally, step 4, carefully cutting and removing the infected organ. And hey, in surgery, every single millimeter matters. The remaining appendicular stump absolutely must be kept under 4 to 5 millimeters. Leaving a stump any longer than that drastically skyrockets the risk of stump appendicitis. That's a brutal complication where that tiny bit of leftover tissue gets infected all over again, and the patient has to go through a second, much more complicated operation. Moving right along to Section 4. Look, surgery rarely goes perfectly to the textbook plan, bringing us to these special surgical scenarios. This is where a surgeon really earns their keep by thinking on their feet. Picture this. It's the classic intern's nightmare. You make the incision, you pull the appendix up, and there is zero inflammation. It looks completely 100% normal. So, what's your very next move?
Well, you definitely don't just close them back up. You have to systematically troubleshoot. First, you search the last 2 feet of the small intestine for a Meckel's diverticulum. That's a small pouch left over from fetal development that can perfectly mimic appendicitis. Now, what if the appendix itself looks fine, but the delicate base is inflamed? You can't safely crush that. Instead, you have to carefully bury the base using a circular purse-string stitch. And in the absolute worst-case scenario, if the base and the surrounding colon tissue are gangrenous or dead, you have to pivot your entire game plan and perform a full right hemicolectomy, removing a chunk of the colon to save the patient's life. Section 5 introduces a really fascinating phenomenon, the appendicular lump. Sometimes, if a patient waits a long time to come to the ER, the body's own internal policeman, the greater omentum, rushes in and walls off the infection before we even get a chance to operate, creating this palpable inflammatory mass. Operating immediately on this kind of lump is incredibly dangerous because all those inflamed tissues are essentially melted together. So we use the Auctioner-Sharon regime, which is conservative management, strict bowel rest, IV antibiotics, and watching them like a hawk. We're looking for one of 2 things. If they improve, great, they go home and come back for a planned, much safer appendectomy 6 weeks later. But if they start spiking fevers and getting chills, it means an abscess has formed. At that point, conservative management is over and we have to go in for immediate extraperitoneal drainage. Finally, we reach Section 6. The appendix is out, but the job isn't done until we review the pathology report. And that brings us into the surprisingly complex world of appendicular tumors.
When it comes to neuroendocrine tumors in the appendix, size dictates everything about survival and surgical strategy. If they find a microscopic tumor under 1 centimeter, this simple appendectomy you already did is totally sufficient. If it's between 1 and 2 centimeters, the next steps depend heavily on exactly where it was located. But if that mass is over 2 centimeters, that carries a huge malignant potential, and it absolutely demands bringing the patient back for a full right hemicolectomy to ensure the cancer hasn't spread into the lymphatic system of the colon. And then there are mucinous tumors. These are terrifying because they can rupture and literally fill the entire abdomen with a jelly-like malignant disease known as pseudomyxoma peritonei. To fight this, surgeons use aggressive cytoreductive debulking, physically stripping out all visible disease, and follow it up immediately with HIP. That stands for hypothermic intraperitoneal chemotherapy. Basically, they pump highly concentrated liquid chemotherapy, heated up to around 41 degrees Celsius, directly into the open abdomen. It's essentially a hot chemo bath designed to eradicate every last microscopic cancer cell right at the source. All of this really leads to one massive final thought to wrap up this explainer. Given how incredibly fast a simple case of appendicitis can escalate from some localized belly pain straight into complex oncology and heated chemotherapy, are we vastly underestimating the humble appendix? It totally reframes how we look at this tiny organ. And honestly, it leaves you wondering what other routine medical emergencies are hiding such incredibly complex depths. Thanks for joining me today. Keep studying and stay curious.